Okay. Thank you so much for the invitation. I'm eager to talk to you today about Mesoamerican nephropathy, a chronic kidney disease epidemic in Central America. I have no relevant disclosures. The objectives today are to understand the epidemiology, clinical characteristics, and suspected causes of Mesoamerican nephropathy. Also to appreciate the emerging role of heat in chronic kidney disease. So the story of Mesoamerican nephropathy really begins with this gentleman whose name is Ramon Trebonino. Dr. Trebonino is a nephrologist in El Salvador who in the late 1990s was a trainee studying to become a nephrologist, and he made a extremely interesting observation. He was rotating through the dialysis unit, and he found something surprising. Like the rest of us, he'd learned that most people on dialysis develop kidney failure due to diabetes, high blood pressure, or glomerulonephritis. But the patients he was seeing were, the patients he was seeing were had no diagnosis at all. So for the next year, he recorded every dialysis patient who was admitted to the hospital and their presumed reason for dialysis. And at the end of that year, he published his results with a quite remarkable finding. Only 15% of them had diabetes as a cause of end-stage kidney disease, 7% had hypertension, and more than 2/3 had no diagnosis at all. And this was really the first report in the beginning of the study of Mesoamerican nephropathy. Now, early reports of Mesoamerican nephropathy were mostly noted in agricultural workers and specifically in sugarcane workers. People immediately thought this was going to be due to an agrochemical, a pesticide, or an herbicide that was harming the kidneys of the people exposed to it. But over time, it emerged that other groups of workers were also affected. These included miners, underground miners, and brick makers and stevedores, the men who load and unload boats at the harbor. And it soon became apparent that this wasn't going to be an open and shut case of agrochemical poisoning, but something more difficult to solve. So next, the epidemiologists came in to try to understand the pattern of disease in Central America. And here's some of the things they noticed. You can see on the map that the epicenter of the disease is really in Nicaragua and El Salvador, but the pockets of disease extend as far north as Mexico and as far south as Panama. The disease is found along the coast in low altitude regions. You'll see that it's only observed on the Pacific coast. It's primarily seen in agricultural workers, but as I mentioned, it's also found in other manual laborers, and specifically people who do heavy labor in hot climates. It's found much more often in males than in females. People say the ratio is somewhere between 10-1 and 20-1. And that's presumed to be due to the different occupational distributions, with most men working outside the home and women working inside the home. And in some communities, the disease is so widespread that 40% of the men in the 20 to 50 year age group have chronic kidney disease. So early opinion was that the common risk factor across countries and across communities, it may be strenuous labor in hot, humid climates. Let me give you a sense of the scale and scope of this problem and to explain what I mean by a hotspot. So the graph on the left shows rates of mortality per 100,000 people from kidney disease throughout the Americas. And if you look at that graph on the left, you'll see the United States down at around 4 deaths per 100,000. And a full 10-fold higher, you will see Nicaragua and El Salvador, where they have 40 deaths per 100,000 in the country as a whole. That doesn't tell the whole story. If you look at the figure on the right, you see a map of Nicaragua broken up into the different departments And departments are like counties in the United States. And in the hardest hit departments, these are Chinandega and Leon in the northwestern corner, rates of kidney disease are up to 20-fold higher than some other regions of the country, suggesting that the disease really is heterogeneous and found in clusters of extreme prevalence of chronic kidney disease. And I'll say a few words about the clinical characteristics of Mesoamerican nephropathy. The consistent features are young age at diagnosis, generally between 20 and 50. These young men in general have no traditional risk factors for disease. And in fact, if they have diabetes or high blood pressure, they're not considered to have Mesoamerican nephropathy. They have minimal proteinuria, at least early in the course of disease. Unsurprisingly, they have small echogenic kidneys. And the biopsies, the handful that have been done to date, show primarily tubular interstitial disease, much greater than glomerular disease, though it is not unusual for someone to have large glomeruli and FSGS, which is presumed to be secondary because of the severity of the tubular interstitial disease. Other frequent manifestations of disease are hyperuricemia, with serum uric acids in the 10 to 15 range being not at all uncommon, and a strong family history of disease. And the kind of gout you can see in these communities is often quite impressive, as shown by the figures on the right. And then more inconsistent features sometimes reported are hyponatremia, hypokalemia, hypomagnesemia, and leukocyturia. So there's as of yet no strong consensus on what the etiology of Mesoamerican nephropathy is, and there are strong proponents for many different candidates. These include toxins, both industrial toxins like agrochemicals, but also environmental toxins such as Aristolochia, which causes bulk nephropathy. Other candidates are medications, particularly NSAIDs, which are used quite profusely, especially by these workers doing very heavy labor. And also antibiotics like gentamicin, which at least until recently you could buy over the counter in the drugstore. Infectious etiologies are broadly considered, specifically renal tropic infections like leptospirosis and hantavirus, but also the more common systemic infections with malaria, dengue, Zika virus, chikungunya, and other endemic viruses. And also heavy metals, which are known to cause chronic kidney disease and are very rich in the environment because the soil there is highly volcanic, and these heavy metals get into the water system, especially into wells that people have at their homes. But still, probably the leading hypothesis is heat and heat stress as a cause of kidney disease. So we'll talk a little bit about how that may happen. So first, I will just give you some more epidemiologic evidence that heat really is a cause, in addition to what I already told you before, that it is a common risk factor between the groups of different workers who get disease, such as sugarcane workers, brick makers, miners. There are other common potential risk factors. Silica exposure is being actively evaluated, but heat appears to be the common thread across all the groups who do get the disease in the region. There are also some interesting, more granular assessments of heat exposure and heat stress. If you go to a sugarcane farm and look at all the different job tasks, there's a very strong dose-response relationship between the degree of heat exposure and likelihood of disease. Cane cutters, that's by far the hardest job. They get by far the most disease. Irrigators are next, followed by fumigators. They get moderately high levels of disease. And then the other workers, such as the drivers, the factory workers, the supervisors, are at lowest exposure, and then they get the lowest risk. They're at lowest risk of Mesoamerican nephropathy. So the dose-response relationship does give some credence to the idea that heat stress may be important. And last, there is a fairly strong correlation between temperature and outdoor temperature and Mesoamerican nephropathy, even within a country which is entirely in the tropics, such as Nicaragua. The 8 different rows on the figure on the bottom right show histograms for maximum average daily temperature throughout the country, and the region where Mesoamerican nephropathy is common is the pink, and that's the row second from the top. And the row above it in gray is the hyperlocal region with extremely high rates of Mesoamerican nephropathy. You can see the average daily temperature is hotter in these regions, but perhaps even more important is the far right tail of the curve, the extreme temperatures that are achieved in these regions. And those are really strongly correlated with development of Mesoamerican nephropathy. So epidemiology looks interesting, but perhaps not by itself compelling. So let's dig in deeper. So whenever there's an epidemic, you really do have to ask yourself the question, why here and why now? And I'm going to tackle the why now part of the problem first. So this figure on the left shows global average surface daily temperatures throughout the world over the last century or so. And you can see a steady monotonic increase in the rates of in the temperature, really picking up around 1980 and continuing to get higher through today. And again, this is one reason why we may be seeing more of the disease than we used to. And these are average temperatures. And like I mentioned, it may not be the average temperature, but the extreme temperature, which is the greatest risk factor. And extreme temperatures are increasing even faster than average temperatures. So making it plausible that workers are exposed to some extremely hostile conditions multiple times a year in the course of their work. The second reason we might think about why now is a major change in the sociological organization of the society in these regions. So up until about the 1980s, most of the laborers were working for themselves on small farms and doing small harvest. Starting in about the 1980s and continuing through today, these small farms have been aggregated by massive agro-industrial businesses where the workers no longer work for themselves and are their own bosses, but work piecemeal. And in the example of sugarcane cutters, they get paid for every ton of sugarcane they cut each day. So they're really incentivized to work as hard as they possibly can to support themselves and their families. And this may put them at also increased risk of heat stress when they are trying to get the most possible labor done in every day, regardless of what the conditions are. So those are the global and regional considerations. But let's turn to the question of, does heat stress really induce kidney failure? I think in extreme cases, we know it does. Example being this, seen in many parts of the world, but a great example is these studies from the late 60s and early 1970s among South African gold and diamond miners, where it was not unusual to pull a miner out of the mines with severe heat stroke, temperatures, core body temperatures over 105 degrees, really severely ill systemically. And the figure on the bottom left shows some case series where they measured the GFR, showed severe declines, but these were young, healthy men who did show improvement after that. But as you'll notice, in most cases, they don't improve all the way back to a normal GFR, suggesting there is some residual damage. Now, in a few cases, biopsy studies were done, and these were often weeks to months after the heat stress event. And what you'll notice is that the pattern of injury on biopsy is this fairly dense interstitial nephritis with a pronounced interstitial infiltrate. Now, this is useful because we know the relationship between the AKI event and the biopsy, but keep this image in your mind because we're going to return to a similar image in a few slides. So it's pretty clear that a heat stroke with a core body temperature of 105 will cause severe systemic illness and acute renal injury. But what about more typical kinds of heat exposure that might be faced by the workers in the field? Now, so I'm going to show some what I think of as beautiful physiology studies from the 1950s. These two studies, or these two graphs, are a superimposition of renal plasma flow and glomerular filtration rate during heat stress experiments over with time on the x-axis and the renal plasma flow, or GFR, on the y-axis. And what you can see is that when people start to exercise, their renal plasma flow goes down, not unexpectedly because they're diverting blood flow to their muscles. But because of the amazing properties of the kidney, the GFR is barely affected at all. It stays completely flat, and that's because of renal autoregulation, which keeps GFR steady over a wide range of perfusion pressures. Now, when you add in exercise plus heat, you do start to see a somewhat larger decline in renal plasma flow, and you see a bit of a decrease in GFR, but again, it's less than you might expect. You've started to divert blood to the skin in order to try to dissipate heat, but GFR doesn't change much at all. However, when you introduce dehydration into this experiment, everything changes. Renal autoregulation is overwhelmed, and suddenly both renal plasma flow and GFR fall off a cliff to the point where they have to stop these experiments early. And this suggests that somebody exercising in high heat in a dehydrated state is probably always teetering on the brink of acute kidney injury. I believe in the course of my research, I observed this accidentally or serendipitously while recruiting participants for one of my genetic studies in Nicaragua. We were out in the fields and we recruited 330 apparently supposedly healthy controls. But when we measured their serum creatinine in the lab, a substantial number had quite significant elevations in their serum creatinine. We knew they all had normal creatinine at the beginning of the harvest season because everyone is checked, and if your creatinine is elevated, you don't get hired for the harvest. We found that 10% had a substantial elevation in their serum creatinine, meaning they'd had acute or subacute kidney injury that had occurred sometime in the previous days, weeks, or months. We followed these people with kidney injury out 6 months and 12 months. And like with the South African diamond miners, many of them, and even most of them, recovered, but a substantial number of them maintained a elevated serum creatinine months to a year afterward, clinically meeting the definition of CKD, and suggesting that this was probably a common occurrence among workers out in the fields every day. Now, interestingly and fortunately, at the same sugarcane farm where our team was doing our research in the fields, another researcher named Rebecca Fisher was doing research in the clinic at the farm. And it was fairly common for workers to come in with a fever, an elevated creatinine, symptoms of volume loss, but a sterile urine when it was analyzed by urinalysis and culture. And they were able to biopsy many of these workers, again, usually weeks to months after the AKI event, and they saw exactly what had been seen in these South African miners, a tubular interstitial nephritis with a dense interstitial infiltrate, suggesting that potentially this repetitive injury was causing, probably if you'd done the biopsy earlier, you might have seen ATN, but this pattern of recurrent injury may be leading to a immune response, cells coming in to try to clean up the damage, and an interstitial nephritis-like pattern. So now I'm going to tackle the second important part of that question about you need to explain an epidemic, which is why here? Now, I should say that Mesoamerican nephropathy is part of a constellation of places where you have these hotspots of chronic kidney disease. And those include India and Sri Lanka being the best described. And these all fall under the umbrella of a disease entity known as CKDU or CKD of unknown etiology. But if this is really due to heat, and certainly all these sites are very hot, it does raise the question why it's so focal. Why don't all these other places in this tropical region enclosed in the red border in my figure, especially sub-Saharan Africa, why aren't people getting CKDU or some Mesoamerican nephropathy equivalent in all these places? And that's a major interest of mine that I've been trying to figure out for some years. So I think it's really important to ask the question, what's truly unique about this environment where people get Mesoamerican nephropathy? But it's also, in my opinion, equally important to ask the question, what is unique about the inhabitants of these regions? And is it possible they have some unusual susceptibility to kidney injury that makes them predisposed to this disease? And I think it's interesting that this is a population that gets Mesoamerican nephropathy. Is an admixed population with Native American, European, and African ancestry. And I was particularly interested because the Native American ancestors of the current population spent thousands of years adapting to Arctic climates before starting their journey downward to Central America. And it was a hypothesis of ours that the adaptation to the Arctic conditions might have caused problems with certain elements of doing strenuous labor in hot climates, such as being efficient at dissipating heat or having lost protection against infectious diseases of various kinds, potentially. So to that end, we really focused on answering a couple questions. The first is, why don't people working in all these other very hot regions who are exposed to similar risk factors in other tropical climates get kidney disease? Is it possible that there are major differences between populations in terms of susceptibility to heat stress? And the second question is, why is it that some workers get Mesoamerican nephropathy after a year or two of working in these hostile conditions, while others working side by side with them don't get disease even after decades of doing the exact same jobs? This is hard to explain without invoking individual differences within a population. So over the past more than a decade, working with a team from Boston University and local investigators in the field, we've done several studies of genetic susceptibility to Mesoamerican nephropathy. And I'll briefly summarize in just 2 slides what we found over that time. So analyzing about 650 controls and about 825 cases, we were in fact able to confirm that risk for Mesoamerican nephropathy is highly associated with the percent Native American ancestry that a worker in the field has in their genome. And let me just walk you through this figure on the right. So if we consider people with a relatively low amount of Native American ancestry as our reference group, in this case, it's people with 40% or less of Native American ancestry, and call them our baseline, and then compare them to the groups with high amounts of Native American ancestry on the far right. These are people with 65% or more Native American ancestry. We see a huge difference in risk, such that those people with a high fraction of Native American ancestry are 6-fold more likely to develop the disease than people with low amounts of Native American ancestry. We've done everything we possibly can to rule out some kind of stratification that we not related to genetics. but we haven't been able to see anything. So at this point, we do believe that this represents a genetic effect, some variant in Native American contribution to the genome that's important, potentially much like the APOL1 risk alleles found in high rates of kidney disease in African Americans. In addition, we were able to find one genetic variant that was strongly associated with kidney disease in this population. And these were genetic variants in a gene called OPCML that were associated with about a six-fold protection against Mesoamerican nephropathy. Now, these variants were actually found not in people of Native American ancestry, but in people of African ancestry, and suggested that there were protective factors in addition to possibly risk factors. Now, OPCML turns out to be a gene almost exclusively expressed in the brain. But one of where it was originally described is in the vasopressin secreting cells of the hypothalamus, suggesting it may have some important role in regulating vasopressin excretion and control of salt and water by the kidney. So we were able to test that in our population, and what we found is that the protective variants that were contributed by from people, ancestors of African ancestry, were associated with an enhanced urine concentrating capacity among sugarcane workers, suggesting there was indeed a protective effect. And then we used mouse knockout models to do a whole bunch of different kinds of physiological challenges. And again, we were able to see that OPCML does appear to be important in regulating salt and water handling by the kidney, and furthermore is important in regulating core body temperature, at least providing a plausible possibility that these variants are indeed part of a gene-environment interaction with heat or heat stress is the environmental trigger, and these gene variants as the genetic susceptibility factor. So one last quick study I'll cover very quickly. You may say to yourself, oh, okay, this is all interesting, but this doesn't apply to my patients. Maybe it does. I'll just very quickly summarize this, I think, ingenious study by Ben Kaplan and colleagues from London, who looked at a reanalysis of the DAPA-CKD trial and just asked the question, could we observe any difference between EGFR decline in high heat sites versus temperate sites? And I'll quickly summarize to say, when they compare people at the hottest 5% of sites versus people at the median sites, they see a almost 4 mil per minute per year faster EGFR decline in people at the hottest sites. When I saw this, I just assumed, oh, that must be because SGLT2s are, a mild diuretic. But the neat thing they show in the red box is that the effect is exactly the same whether a participant was getting placebo or the DAPA. So it does suggest that there may be faster EGFR decline in populations in high heat environments who are otherwise much the same, even after control for all the different socioeconomic factors. So maybe it is important for all of our patients. Okay, my final slide, just my take-home messages. Mesoamerican nephropathy occurs in hot spots where one common element is strenuous labor in hot, humid climates. Repetitive AKI episodes may lead to accumulated kidney injury. Biopsies tend to show tubular interstitial nephritis with varying degrees of inflammatory infiltrates. There are differences in susceptibility between populations and between individuals within a population. And I'm pretty sure that other environmental factors are also probably important in specific hotspots. And just very quickly, my questions. Which feature of Mesoamerican nephropathy is correct? It occurs about equally in males and females. It's associated with high-grade proteinuria. It's hard to distinguish from diabetic nephropathy, or it's often associated with high uric acid levels. Give you a few seconds. The answer is D. often associated with high uric acid levels. Second question, Mesoamerican nephropathy is one presentation of CKDU. Other major hotspots of CKDU include Sri Lanka and India, Australia, New Zealand, the Balkan states, or South America. And again, I give you a few seconds. The answer is A, Sri Lanka and India. Okay, thank you very much. I'm sorry I'm a minute over. I'll be back in an hour to answer any questions if there are any. Thanks very much, Dr. Mount. Back to you.